Hey, good afternoon, and thanks for joining us here on this Friday. We're a little bit behind schedule, about 18 minutes behind our regular start time, but thanks for joining us here for this Adventist Health Wellness Connection. Today, we are kicking off Breast Cancer Awareness Month just a smidge early, right? It's the month of October. We're still in September, but it doesn't feel like that outside for sure. It's a little warm here for September, but hey, it's Bakersfield, so we'll take it. Joining us now to talk a little bit about breast cancer, Dr. Francesca Haney and Dr. Connie Lee, the only all-female, all-board-certified breast cancer team in Kern County at the AIS Cancer Center at Adventist Health. Thank you guys so much.
Thank you.
All right, so I'm going to give a little bit more introduction on you so people kind of know what you guys do and where you've been. Dr. Haney, board-certified breast surgeon, a California native, and your practice focuses solely on breast diseases, particularly cancer therapy, using advanced treatments and tests to serve your patients. You're a member of the American College of Surgeons, the American Society of Breast Diseases, and the American Society of Breast Surgeons. Dr. Connie Lee, new to Adventist Health Bakersfield. You are joining us officially in a couple days?
Yes, in a few days.
Okay, a couple of days. But obviously has lots of years of experience. Board-certified breast surgeon with licenses to practice both in Massachusetts and in California, and also a member of the American College of Surgeons, the American Society of Breast Surgeons, and the Society of Surgical Oncology. So thank you guys both for coming. And I wanted to point out the uniqueness of this team, of this pairing, right? Because there's a lot of areas not in Kern County anymore, where the service for breast cancer is done maybe by a general surgeon who does a lot of gut surgery and other things. You guys specialize specifically in breast cancer surgery, which is a pretty amazing thing. That's all you do, right? Mm-hmm. So why is that important? I guess maybe I would ask that to begin with.
Well, I think that, one is that it's the only thing that we're focusing on. So when patients come in, we have kind of a luxury where breast cancer is an emergency. So we have the ability to put patients in to be seen the same day or the next day and get them in for their treatment. Mm-hmm. It allows us to work with the plastic surgeon at the same time to provide certain options for patients. We also do a spectrum of disease, anything from benign disease, patients who have family histories or genetics. They're a little different than what the general surgeon might be dealing with.
Right, okay. And I see Joe, Raphael's on with us, Rebecca, and Janie all on Facebook here. We want to make this an interactive session as well. So while we're here talking, we want to make sure that if you have questions about breast cancer surgery, things like that, feel free to shoot us a message right here online on these comments. I'm monitoring them, so we'll be asking some of the questions you guys might have out there on Facebook and on all the other platforms that people are watching, Roku and whatnot, so we can get some of those questions answered, because there's a lot of myths and facts which we're going to be getting to in just a few seconds. All right. So before we get to that too, we want to talk about the AIS Cancer Center. While we're talking about myths and facts, there are folks out there that really don't know a lot about AIS Cancer Center. And I'd heard one rumor that somebody said, "Oh, you guys just work out of a room, like you guys are a room." So we wanted to dispel that myth first and foremost. That is the place they work. It's a building. It's a real building, I promise. It's 60,000 square feet, 4 stories. And the real cool thing is, and Dr. Haney, this goes back to what you guys do, which is unique, is it's not just surgery, it's not just radiation, oncology, it is the full package, so you don't have to go around town to 10 different places. And the nice thing I would argue too is that there's a continuum of care there. You know the other folks that you're referring to, you're in the same building, and that makes it, I would say, a better patient experience, but also better care right at the end of the day.
Yeah, we have a multidisciplinary tumor board as well, which allows us the pathologist, the radiologist, medical oncology, radiation oncology, plastic surgery to sit in a room and discuss cases. So patients do get a comprehensive care, not only from the people that you may meet, but again, radiology, pathology. So we get to actually look at slides and images of the patient, and so everybody's kind of integrated at that point.
And it's a fancy center. We got more pictures to show you, but I mean, it is fancy inside. We kind of like it at the Nordstrom's a little bit, if we can indulge ourselves a little bit. But the other thing that you see up at the top there is the picture of the Valerian TrueBeam, which delivers radiation to patients, and it's brand new technology. I mean, it's just a few years old, and you're looking at the ambient lighting in there, right? I mean, they do it to change the lighting to kind of comfort patients as you're going through probably one of the most difficult diseases that's out there. There's all kinds of things going through your mind, and this is something that we can do, just one thing, right? Just making the mood a little bit nicer in there. Not to mention the fact that the technology is so new that the amount of time that patient has to be on the table is that much shorter, because it's new technology, that they're not sitting there for an hour, right? Waiting to get treated. So Nice stuff. Okay, so we wanted to get to some of the other myths and facts that are out there about breast cancer. And the first one that comes to mind, and Dr. Hay, maybe we'll have you start with this, and then Dr. Lee, we want to get your opinion on it too. Men don't get breast cancer. It's a woman disease, if you will. True or false?
False.
Okay.
That's false. About 1% of men in the general population will develop breast cancer. Some men who carry a genetic mutation are much higher. About 8% of those individuals with a genetic mutation will also have breast cancer. And unfortunately, men are often misdiagnosed, or they kind of ignore it. They think, oh, I hit myself, it's just a bump, I must have done this or that. Even practitioners sometimes say, oh, just watch, it'll go away. And they get diagnosed a bit later because they're just not in tune with that. Whereas women, when you feel a lump, will go in to see their doctor, and everybody thinks, oh, you have to make sure that that's not breast cancer.
Okay, and I see they're genetically positive men, which means that you're positive for one of the genetic markers. That means you have an 8% risk. How does that work, Dr. Lee? What does that mean exactly?
So men with extensive family histories of breast cancers, they get screened and they can become positive for what we call BRCA1 or 2, and most commonly BRCA2. And when they're positive for this gene, it's associated with an increased risk of up to 8 to 11% for men to develop breast cancer.
Which is one of the things I think is interesting, right? Because when we talk about people having the breast cancer gene, that doesn't necessarily mean that you're going to get breast cancer, right?
No.
Because there's an environmental and a genetic factor, right, for this disease. So
Absolutely.
even if you have the gene, doesn't necessarily mean you're going to get it.
That is correct.
Okay,
Yes.
very interesting. And we should take a quick pause here. Rebecca Toledo is asking a question. When should a mammogram be done, Dr. Haney?
If a person doesn't have, if it's for a woman, and you don't have a family history of breast cancer at age 40, and then if you have a family history of breast cancer, it's 10 years before the average person in your family before that first person get breast cancer, you should start.
Okay, great. And we should note we have Nurse Jackie, who is part of our AS Cancer Center team, just off camera here, answering some of your questions on the Facebook feed as well. So again, if you have any questions about breast cancer or cancer specifically to your family, we can try and answer as many of them as we can, or generic questions about breast cancer. We'll answer them as we go. Dr. Lee, fact or fiction, if you don't have a family history, you won't get breast cancer?
That is absolutely false.
Okay.
Family history does play a role, but 8 out of 10 women diagnosed with breast cancer actually have no family history whatsoever. When we talk about family history, we're talking about mothers, siblings, children. Those certainly increase your risk. When you have 2 first-degree relatives, that triples your risk. If you have a male relative with breast cancer, that also increases your risk as well.
Okay, because I'm reading some of the other family history things. I won't get breast cancer because it doesn't run in my family. If breast cancer is on your dad's side, it doesn't count.
That is not true.
Not true. That's like the hair thing, right? If your mom's dad has hair, your hair won't fall out when you're older. So it's not dependent on one side of the family or not.
No, there are actually multiple mathematical models, calculators, if you will, that we use that use one of the factors is family history. You plug that in, you can actually calculate a person's individual risk. Interesting.
Okay, so how does your family history truly influence your risk? Where does that family history play in then?
Well, taking an appropriate family history, so definitely blood-related relatives, that is a big component. When we ask some of our patients, do you have a family history, they start listing off all these family members, but if they're not blood-related, then it doesn't count. But certainly we ask about all cancers, not just breast, ovarian, gastric, melanoma. We're finding now with new genetic predispositions that other cancers are more associated with breast cancer.
Which is really interesting. And the numbers here are interesting too. 2 first-degree relatives triples your risk. So it makes sense, right? The more number of people that are closely related to you that have breast cancer increases your risk. That means that you have a higher genetic predisposition for it.
Yes.
Okay. So Dr. Haney, what role do genetics play in breast cancer then exactly? How does it work? We've been talking about BRCA and these different genes, but what exactly is going on?
Well, we look for, when we screen patients who meet criteria for genetic testing, like Dr. Lee said, we look for a family history of breast and ovarian cancer. We're looking for patients who have particularly family members who were young at their diagnosis, ovarian cancer, some of these other associated cancers that can be screened. It's a genetics, or it's actually a blood test, or actually it's taken from saliva as well. and it's sent to one of 4 labs here in the United States, and they can test, and then it comes back with the results. And we use the results to screen patients and do screening as well as treatment.
So most common gene is BRCA1 and BRCA2. Average 7 in 10 chance of getting breast cancer by age 80. Other associated cancers includes ovarian, as you were talking about, and tends to look for young age, but multiple individuals and related cancers, right? So this is really interesting. And when we're talking about all these there's other associated genes, ATM, P53, there's all these, and I'm going back to my biology from college, cell cycle regulation. So basically, I mean, we should probably go a step back. Breast cancer, or cancer in general, right, is the unregulation of the cell cycle, where cells are growing out of control. That's the basics of what cancer is, right? Yeah. And it's the genetics gone haywire in those cells.
Yes.
So, and the traditional treatment, right, has been, in the past, when we first started, was chemotherapy, which went after all the fast-growing cells, but that's why people have hair loss and fingernail loss and stuff like that, because it's going after every fast-moving cells. But now, as you guys are getting more advanced in treatment, you can target and do gene therapy and do things like that that's a little more specific, right?
Absolutely.
It's progressing. Another question, this one's from Courtney. What about PASH? PASH, I don't even know what that is. Does anybody know what that is?
Pseudoangiomatostromal hyperplasia.
Okay. You may want to say that again, because I didn't know what that was.
It basically is an abnormal, or it's a benign condition, but the cells are growing in an abnormal pattern, so to speak. We do generally recommend monitoring these patients with either excision or close follow-ups with imaging in terms of a mammogram or an MRI or an ultrasound, however they were diagnosed to begin with. I don't know if you have any.
I agree with you.
Okay, so could you say that again, post?
Pseudoangiomatostromal hyperplasia.
Okay.
Try to say that 3 times fast.
I'm gonna go home and Google that, because I don't know what that is. Interesting. Okay, Dr. Lee, some women believe that if they have smaller breasts, they have a smaller risk of breast cancer. Fact or fiction? This is an interesting one.
This is definitely false.
False, okay.
Yes.
So if your breasts are smaller or have less fatty tissue, you're not necessarily less likely to develop breast cancer.
No.
Why would people, I guess, I'm not sure, but I mean, people would assume, I guess, if there's more tissue there, you have a higher incidence or higher chance of getting breast cancer?
I think the fact that you're a woman and you have breasts increases your risk for breast cancer. The fact that they're smaller does not necessarily mean that risk is smaller.
Interesting. Okay, so Dr. Haney, another question that comes up often, dense breast tissue. Because you hear that a lot sometimes, even with the mammograms, right, as the tissue looks dense. What does that mean exactly for a woman who sees that on a mammogram report or anywhere else?
So density is really the percentage of fibroglandular elements related to the relative amount of fat. So density is just basically how much breast tissue do you really have. A lot of this came out of some of the new laws that were passed several years ago regarding mammography and informing patients what their density was. And so if you've had a mammogram report in the last 10 years, patients will notice that they were told what their density is. To be honest, radiologists have always commented on the density of the breast, but now it's actually in a formal report to the patient. So density plays in two ways. There's a slight increased risk for breast cancer depending on the density, which is based on multiple factors. Age of the patient, so if you're pre or postmenopausal and hormone therapy, some genetics. So there's different factors that we can't really control necessarily. But the other part to the density is that it makes screening sometimes a little more difficult by standard mammography. So patients can be suggested, if they're dense, to have an ultrasound as part of an adjunct to supplement their imaging.
Oh, interesting. Okay. Another question coming in from, looks like Bever Rosemarie. How often do you do a routine CT scan and blood test to check for cancer return after having a double mastectomy? Dr. Lee? What's the follow-up right after that? I mean, what does the schedule look like?
So after a double mastectomy, it depends on whether the patient has had reconstruction as well. Generally, as breast surgeons, we follow them up with physical exams every 6 months for the first 3 years and maybe yearly after. In terms of CT scans and blood tests, those are usually scheduled by the medical oncologists. If they're doing a PET CT, that they generally start off every 6 months, and then they can again move out to a year depending on how well they're doing.
Okay, let's get to our next question, or next fact or fiction, myth. If a woman had cervical cancer, she's at a higher risk of breast cancer. Dr. Haney, true or false?
False.
False. Why is that?
People think it's the cervical cancer that's associated with breast, but it's actually the ovarian. So it's the ovarian cancer risk that we're worried about in regards to genetics.
Okay.
With breast cancer.
And is there a reason behind that?
Because of the BRCA1 and 2 genes. It's
Okay.
the way that they play together.
Interesting. Okay. Fact or fiction, Dr. Lee, implants cause cancer.
That is absolutely false.
Okay.
Implants, women with implants, just like every other woman, need to also have their yearly mammograms done. Mammograms are just a little trickier in women with implants. They have to do what is called displaced views. So in order to, if you will, to get a picture of the actual breast tissue, they have to displace the implant to the side in order to see the breast tissue. Makes it really difficult to get all the breast tissue in the image. There are some association with anaplastic large cell lymphoma with certain implants. It's a very rare condition. It's very treatable. It tends to be associated with textured surfaces and older implants. We don't see a lot of it now.
Is it harder to, I mean, you mentioned a displace, but I mean, is it harder to image? Is it easier for a breast cancer to go undetected, let's say, if you had an implant? Or you're saying no, as long as you're getting the correct mammography done?
I think it's hit or miss. I think in terms of physical exam, women claim and physicians claim that it may be actually easier to detect nodules and lumps because you're actually feeling it against the surface of a smooth implant as opposed to the ribs. In terms of imaging, there are spots where mammograms can actually not get because they can't displace the implant in that direction. Yeah, exactly.
Oh, interesting. Okay. Fact or fiction, Dr. Haney, cancer related to the use of underwire bras.
Oh, that's false.
Okay.
Yeah.
It's probably going on a long time, I'd imagine.
Yeah, the theory is people argue that the underwires obstruct the lymphatics and that somehow causes the cancer. There's no truth to that, and there have been studies that have shown that that's not true.
Okay. Heavy smoking, though, over a long period of time may be related to breast cancer, is that right? Okay. And women who start smoking before their first child may be at an increased risk of cancer as well?
Yes.
Okay. Obviously, smoking's not good for you in general, right?
Yeah.
So
there are several things that we recommend patients to decrease risk of breast cancer. One is, we encourage patients not to smoke anyway, but losing weight and being within a healthy weight has actually been shown to decrease your risk of breast cancer and other kinds of cancer. Exercise, routine exercise as well, making sure that your vitamin D level is within normal, which is a blood test that your primary doctor can do, and avoiding alcohol are all things that you can do to change your risk.
Okay, and Dr. Haney, we have another question from a Facebook viewer. Lisa Villardis is asking, what is fibrous tissue? Is that different from
I think
dense?
that's pretty much what we call breast tissue. People have a lot of terms for breast tissue. They'll say, well, I have fibrous tissue. I think a lot of people, that's kind of the texture of the breast, and it's like a descriptive term, just that they're perhaps more dense than somebody else. People also like to use the term fibrocystic, which they say, it's fibrocystic disease. It's not really a disease.
Okay.
It's just the texture of the breast.
Because I'm sure that's what Lisa is asking. Is it abnormal in any way? Is it going to? No. Okay. It's just everyone's body's different, right?
Yeah.
Okay. Fact or fiction, Dr. Lee, hormones cause cancer.
So hormones have been associated with increased risk. We know that women on birth control pills are at an increased risk. When they stop the birth control pills, that risk goes back down to normal after 10 years.
Okay.
Women on combined hormone replacement therapy, especially if they still have their uterus, they do have an increased risk. That risk, again, goes back down to normal after 5 years of discontinuation. And then with estrogen alone, without a uterus, the studies currently are still out, so the jury's still out on that. We may still find an associated risk, we don't know.
Interesting. Okay. This is an interesting one. Needle biopsy spreads cancer. Because when you're going in there, you're doing a biopsy and you're maybe disrupting the potential tumor or spreading the cancer, like kind of seeding it other places. So you're shaking your head, no way.
Absolutely not.
Okay.
No, we actually require core biopsies whenever we find anything extremely abnormal, especially on a mammogram or an ultrasound finding. This aids us in better informing our patients to make better decisions and treatment options, because then it can help us for surgery as well.
Yeah, it's an old myth, and unfortunately it's quite detrimental to patients. There are lots of things that show up on mammograms and ultrasounds that are nothing. They're benign. And so rather than going through the surgery and taking all of those risks and having a scar for something that's a benign condition, seems quite a bit unreasonable, because we have the technology of having the small core biopsy. It's done in an outpatient procedure. It's given under local anesthesia, and it gives us much better information about how to treat patients. And you can exclude a number of patients. There have been lots of national studies that have shown that once you institute core biopsies, the number of patients having unnecessary open biopsies goes down significantly.
And gosh, I would imagine, 20 years ago, without having something like that in place, women were having mastectomies, losing their breasts.
They were.
Because this wasn't in place. For benign conditions, they didn't even need to undergo that. I mean, that's a pretty radical surgery to undergo for no reason, which is pretty amazing. Teresa Wilson's asking, I'm being treated now for breast cancer. I never had a PET, MRI, or CT. Is that typical not to have those tests? And once I'm done with radiation, sorry, I'm getting some interference here on the. Once I'm done with radiation, how will I know that they killed all the cells?
That's a really difficult question. And the reason is because in order to give you kind of an idea, every person's tumor is different. So what we do for one person is not always the same for the next. So it's easy to kind of say, well, this person got a PET CT scan and they're getting one every 6 months and I'm not. Mm-hmm. That's not necessarily
a bad thing.
And it's not considered the standard. We can't just look at one person and say, well, they're getting this and I'm not. So I would say, look, you have to look at the tumor, what you were diagnosed with, how you were treated, meaning what surgical options were performed. Did you get chemotherapy? Did you need chemotherapy? Did you take a pill? There's so many components to that it's hard to answer that question. Okay. So there's really not a standard. And if you look at the national guidelines, depending on which stage you are, they don't really recommend PET CTs routinely. They don't recommend MRI necessarily for our patients post-surgery. So it ultimately comes down to the fact that every cancer patient is different, and we have to treat them each differently. And so because you're not getting the test, it doesn't mean necessarily that's a bad thing, and it doesn't mean that necessarily you need to have all the tests done either.
Sometimes it's unnecessary. It's not the standard of care.
It's not the standard of care to necessarily, for every patient, to get a PET CT every 6 months. Certain patients should.
Yes.
But the majority of patients, thankfully we're finding small tumors, don't necessarily need those tests.
Okay, and it's interesting that we had this graphic come up. Breast cancer treatment is individualized. Every tumor is different, right? Some of them are positive, HER positive, some of them are not. So how genetics play into all this, and your family history determines on how you guys treat it, right? It's an individual treatment plan.
Absolutely.
So how would it be different from one woman to the next? Say if there is a HER positive versus how do you decide and make that decision?
Well, with the core biopsies, we're actually able to send that tissue off and test for certain receptors, estrogen receptors, progesterone receptors, and something called HER2. And we can individualize treatment based off of these receptors, and not only that, size and whether or not the cancer has spread. So every treatment plan is nuanced, and it's, I think, very individual based. So knowing more about the cancer is always a good thing.
So one that might be more aggressive, a tumor that might be more aggressive that's positive, let's say you might treat more aggressively,
exactly.
right? As opposed to
like the triple negatives that you hear about.
Okay, very interesting. And Teresa, thank you for your question. And we're going to, again, take all your questions here. This is really interesting, and some of these are really kind of very personal, which is nice that we're able to answer some of these questions. And one of our other questions to Dr. Haney was, and she says thank you, by the way, for answering that. Does
you're
help
welcome.
her. Teresa's question is, how do you know at the end of all this that you actually have removed all the cells, that there aren't lingering? Is there any way of knowing for sure? There's maybe not no way of knowing that for sure?
I think anybody who has cancer always has that worry. I think that's fundamental, and it comes down to, and unfortunately this happens to patients, and when I see them years out, we have this conversation that, life goes on, right? You have to trust, like that kind of the slide said, you have to trust that you've had your care and that you're doing well. We use what we have. We're going to take our pathology and make sure our margins are clear, and we've checked your lymph nodes. You may get your scans, you may get blood tests, you may go through all of that. But ultimately, breast cancer is well treated and patients do well over time. That sneaking fear and suspicion of patients that, what if,
Right.
is unfortunately really common. But it's really that confidence in that, when we do surgery or when we give radiation, we are targeting with the best equipment. We're trying to do the most complete surgery to make sure that everything is out for a patient.
But do the least amount of harm. You don't want to take good tissue
Yes.
at the same time,
Yeah.
right?
Yeah.
Which is kind of a hard decision sometimes, I would imagine. When you're getting in there, you don't want to take too much, but you don't want to leave anything behind.
Yeah, and that's part of the art form that you have, and when you're dealing with it, just like the radiation oncologist is making sure that he gives enough radiation to a particular area, and they're using the CT to plan specifically this. It's really amazing just the minute detail that when your patient's going through treatment, that patients are being imaged and treated with.
Because the best way of imaging, which we were talking about at the very beginning of this broadcast, where you have the latest technology now, can pinpoint, within a tiny millimeter, right, of where that tumor is. So you're getting only the bad stuff and none of the good stuff, because you don't want to burn bad tissue. You don't want to get radiation burns, which is relatively rare these days. But you don't want to kill good tissue along with the bad.
Yes.
So, okay, another fact in fiction. I have a lump, but my mammogram is negative. I shouldn't worry, Dr. Lee.
That is absolutely false.
Okay.
A mammogram is just one of many imaging tools. We have ultrasounds, MRIs that we mentioned, and CAT scans even. Just because your mammogram is not able to pick it up, we can use other imaging modalities to see if it actually is concerning or not.
Okay, and ultrasound, MRI, and then biopsy is the ultimate one. So how do you know, I guess maybe in my own mind, maybe I don't fully understand it, but when do you know it's definitely benign versus malignant? Is through the biopsy?
So there are actually multiple ways based off of mammogram and ultrasound by the way the lesion looks. If it's well circumscribed, there's like certain terms that radiologists can describe these lesions as, and we as surgeons know what to look for as well. And then they can actually rate it on a BI-RAD score, which is their categorization of how worrisome a lesion looks. And beyond a certain number, they recommend biopsying. So we don't biopsy everything that we find. Otherwise, I think we'd be subjecting women to a lot of needless biopsies. But we do biopsy the ones that look suspicious.
And that's a standard, right? I mean, it's a standard across the country.
Standard
No matter
across
where you go, world, right? You go to another, they all use the same scoring system, so that
Exactly.
we're all speaking the same language, and people are not looking at two different things, which is really interesting. Fact or fiction, Dr. Haney, if a woman has breast cancer, she will need a mastectomy, chemotherapy, and radiation that potentially could make her hair fall out.
No.
Okay.
No. So kind of we were talking about before, treatment is personalized today to each individual patient. So each tumor and each patient is given their own plan of care. So there are different options. People don't necessarily always have to have a mastectomy, lumpectomy, or partial mastectomy can be completed. Patients can have a mastectomy with reconstruction, different kinds of reconstruction. A lot of patients don't need chemotherapy. There's new technology called Oncotype that can tell you what your chances of recurrence are and whether or not you'd benefit from chemotherapy. And new studies as well on radiation and who benefits and who doesn't.
Yes.
Okay, and Teresa's saying, as she's watching this, just wanted to add early detection and mammogram saved my life, right?
Oh, yeah.
Which we're going to get to in a few seconds, because we have some interesting numbers to talk about, which is actually quite newsworthy, and that is breast cancer is becoming kind of an issue with young women in Kern County. But before we get to that, Dr. Lee, fact or fiction, women can avoid getting breast cancer? Is that something you can do by lifestyle modification, diet, exercise?
No. Just the fact that we have breasts puts us at an increased risk for breast cancer.
Okay. So, I mean, there's stuff that they always say, like with heart disease, too. You can run away from exercise and bad diet, but you can't run away from your bad genes, right?
Correct.
So if you've got the genetics, and potentially if you're exposed to certain things that we don't fully understand yet, you will develop breast cancer potentially.
Yes.
So, okay. Let's talk a little bit more about risk factors for breast cancer. Dr. Haney, what are some that women need to keep in mind? You said, Dr. Lee, being a woman, which is 100 times more common in women than men for breast cancer, but age. So does your age go up or decrease when you get older?
So breast cancer tends to be more common as we get older. People sometimes say, well, I'm too old to get breast cancer, so I'm too old to get my mammogram. That's totally false as well.
Okay.
People sometimes say, well, I'm too young to get breast cancer, and unfortunately that's also false. So it tends to be more common in women, tends to get more common as we get older. As I mentioned before, you can modify some of your risks by losing weight, exercising, avoiding alcohol, and make sure your vitamin D level's normal.
Okay, so lots of things you can do. Personal history, though, does, obviously we mentioned increase as well, right? If you have a familial relationship to somebody that's had breast cancer, will also increase it as well. And again, we want to remind you too, over at the AIS Cancer Center, if you want to attend one of Dr. Lee's breast health free lunch and learns that's coming up October 9th. Topics include, as we've been talking about here, dense breast tissue, breast surgery, plastic and reconstruction surgery, and follow-up care. We just ask that you RSVP if you're planning on coming down. Again, that is at the AIS Cancer Center coming up 637-8321 is the phone number to call, 637-8321, and we can get you more information about coming on down and doing a free lunch and learn with our team, our breast cancer team, so you can ask maybe questions if you're not interested in putting it on Facebook out there. You can ask Dr. Lee in person, which is always great. Let's talk a little bit about age. This is something that's concerning young women getting breast cancer. Dr. Haney, can you be too young to get breast cancer? And what's the youngest, I guess, maybe case that you've seen?
Well, the youngest, I've had patients that are in their early 20s who have breast cancer, unfortunately. Obviously, they usually come in because they have a lump, because they're not doing the regular mammograms. So they come in with a little more advanced disease sometimes, unfortunately.
And this is something that's interesting. We'll probably talk to Nurse Jackie, who's going to come up and join us in a few minutes here. Looking at Kern County, our rates are not very good in terms of when it comes to breast cancer. I think it's something around 15% is where we're at with breast cancer rate for the population here in Kern County. Is that right? Yeah,
we happen to look at the numbers in our center particularly, and compared to the national average, we're about 15%, which is about 3 times higher than the national average. We're not really sure why we see much younger population than on average, but
well, that's always the question, right? Are we doing a better job scanning for it, looking for it, so now we're seeing more of it, or is it just that there's something unusual going on here in Kern County? We don't have an answer, is that right?
We don't, and people, though, at national conferences have mentioned, with the number of younger patients that are being diagnosed, that some of this has to do with just population dynamics. There's a larger, younger population, and so it just looks like you're having a larger number because of that.
Okay, and we want to go back to that graphic and just kind of keep talking about that. So it looks like a larger number, but does that mean, it goes back to kind of your conversation or point a few minutes ago that women need to come in earlier, right? That's the most concerning part. Not only that we have younger women that I think are being diagnosed, but the fact that they're coming in with later stage of the disease, at stage 3, stage 4, that's alarming, right? That they're not coming in earlier because, talk to me, I guess, maybe about what it's like being able to treat a stage 1 breast cancer versus something that's stage 4.
Well, stage 1, obviously more treatable. We look at the survival advantage for patients who are younger. We look at options for treatment as well for younger patients, mastectomy versus lumpectomy. We look at genetics a little more commonly for patients who are young at their diagnosis. We look at fertility issues with these patients and associated risks of cancer such as ovarian.
Okay, and we made a little bit of a swap-a-roo here. Another special guest, Jennifer Hennick, a nurse practitioner over at the AIS Cancer Center here at Adventist Health. Also, we should note, a breast cancer survivor, so yes. Congratulations.
Thank you.
Jennifer, you were diagnosed with breast cancer at a very young age. First up, how old were you when you found out, and how was your breast cancer discovered?
I was 28, and I discovered it myself while I was taking a shower. Just like most young women who are diagnosed with breast cancer, I think 80% of them find their own lump. So,
what was that like? Were you a nurse? You're a nurse practitioner at our
at that time. At that time, I was in nursing school. I was in the RN program, my final year, when I detected that lump.
What was that moment like for you? Right?
It was tough. There was a lot of stuff going on in my life at that time.
I can imagine.
To have to deal with cancer now, or this lump, and deal with that was. It was a lot. So I was in school full time. I had 2 babies. They were 5 and 3. I had been divorced and was actually dating at the time. Worked a full-time job. So there were all sorts of things going on in my life when I found that lump.
How does it inform, I would ask, maybe it doesn't, but how does it, I would imagine it does, the way you treat patients now? Now having been a survivor and gone through the disease process, what is that like? Because you've kind of been there, right?
It's awesome. It's amazing. And I always tell people that's the silver lining that came to me with my breast cancer diagnosis, was finding that this is the place that I need to be. This is why I'm here, to treat these patients. Because otherwise I would have never even considered going into oncology. But just my experience alone, especially with the nurses who treated me, just the way they cared for me and everything, it really sparked that
your
desire
passion
in
to want to
me.
go back and help back.
Absolutely.
What was it like being diagnosed, I guess, at a young age? Because we may have some young folks, especially on Facebook, who are watching, who'd be interested to know what it's like. I mean, that's got to be devastating. You're not thinking at 24 or 25 years, oh, I'm going to have a potentially terminal disease.
No, like I said, it's a lot to take in, and especially at that age, you kind of feel like you're alone, because the your breast cancer counterparts are usually in their 50s, 60s, 70s, and here I was at 28, and you feel alone a lot of the time. So it was really rough. Thankfully, I had a lot of really good friends in the nursing program, and at the time, my family lived out of state, so there were a lot of things and a lot of young women that get diagnosed at that age, they have to kind of juggle all those things.
And there are resources at the Cancer Center now, right? AS Cancer Center for young women that are diagnosed because before, when they didn't have those resources, as you were saying, kind of alone. Now there's kind of some wraparound, right?
Yes. So the Young Survival Coalition is the largest national organization that is dedicated to the unique needs of young women who are diagnosed with breast cancer. So they also have face-to-face networks around the country. So I have one here in Bakersfield. We base it out of the breast center. So we have currently 54 girls that are part of our group, local girls here, that are able to access those resources. So they're able to meet with us face-to-face, and they're also able to access the online resources with research and things like that.
What kind of resources are women looking for, especially as a younger person, right? I mean, a lot of what you're doing, I can imagine any young person Googling. That's the first thing you do, right? When you hear breast cancers, oh my gosh, what is this gonna,
fertility, like, oh my gosh, I wanted to have a family, and now what do? I'm faced with having to deal with chemotherapy that could lessen my chances of that. Financial. At the time that I was diagnosed, I was a poor student and I didn't have insurance coverage. So a lot of us don't have insurance coverage, and we're having to kind of manage that and figure out how we can get that.
How we can pay for all of this.
Yes. So, and like I said, dating, your body image at that time, at that age, is a tough one to deal with, especially when you're dating too.
The prospect of potentially having a mastectomy.
Yeah, small children, looking at my small children and thinking, God, I don't want to leave them without a mother. I mean, that's really tough.
Sure. And so there's a lot of resources out there. One of the things that's coming up, we're really excited about, we've been doing it for quite some time, is VI Pink. And we made it, again, because sometimes when people think about breast cancer, it is an ominous thing, but we want to make it a fun night of prevention and getting out there and getting the word out so that we can catch this stuff early, right? So VI Pink is coming up October 11th. It is at the AIS Cancer Center, 5:30 to 8:30. Again, we're on Chester Avenue, and you just come on down to the breast center, and it's kind of a celebration of life. We do have survivors out there. We do a fashion show with our survivors. They walk the runway, and it's a night for kind of women to support and celebrate women. It is a good time out there. Jennifer, Facebook, is that the good place? What's the best way, I should probably ask, to connect with the Young Survivors group?
I would say definitely go to Facebook. We have our private group page there, so you would just search Bakersfield Young Survival Coalition face-to-face network. But if you just put in Bakersfield Young Survival Coalition, you'll come up with our private page. You just ask to be a part of it, and then we'll get you in there. We do lots of really fun things together. Every Saturday we do yoga at noon at Warrior One, thanks to Dana Healy, the owner there. She offered that space to us. And then Kelsey Wilson is our instructor, and we just love her. So every Saturday we're down there connecting with each other. We do paint nights. We've gone to theater. We just have a really good time together, because it's just amazing, that feeling that you get just being in a room with girls that have been there. It's just you don't even have to say cancer.
Right.
And
they know.
It's just that spiritual connection. So it's an amazing group.
That's fantastic. Dr. Haney, another question, this one from Melissa Laughlin Howard, and I'm trying to read through some of the comments here. It's a little bit blocked down here. It says, I have dense fibrous breasts and have had annual mammograms every year since I turned 40. At 61, would I be better off switching to digital mammograms? Is the added radiation risk worth more of the accurate visualization?
So I think what she's referencing is the 3D or tomosynthesis for mammography. Most mammograms are now all digital. I'm a big believer in 3D mammography. The studies show an improvement in detection, but also a decrease in false positives. And so you're getting both the benefit. The uptick of radiation is very slight for a 3D, but I think you have to really that really outweighs that risk is really little compared to the real benefit you're getting from that mammogram.
What is it like, I guess, compare it? Is it like watching high definition television versus standard definition television? Put it kind of for, like, I guess, the folks who have never seen a mammogram before.
So I kind of think of it as having a live view. You know, when you have an iPhone and you do your little live shots and they kind of move, it's the same thing. It's instead of having just the picture, it kind of moves through your breast tissue, and so it scans in a different way, and you're seeing the tissue kind of through the tissue, not just a picture. It kind of looks through the tissue and gives you a little bit more definition in there. And I definitely have seen a benefit in it.
Okay, so it's worth the while. We want to note another thing that's happening, a free clinical breast exam event that's coming up at the AAS Cancer Center. That is coming up October 24th from 4 to 6 p.m. And it's the National Comprehensive Cancer Network recommending clinical breast exams every 1 to 3 years for women between the ages of 25 and 39, and every year for women 40 years and over. So clinical breast exams, different than a mammogram, Dr. Haney, you can maybe explain this, but you're actually, you obviously suggest women are doing self-exams at home, but this is actually having a physician who's experienced and has, knows about breast cancer, kind of take a look at what may be going on and making sure you're not missing any tiny bumps. Is that right? What is it like for a clinical breast exam?
So good breast health includes two things. One is your mammogram, but the other part that people sometimes think, because their mammogram's fine, I don't need to go see my doctor, is really that clinical breast exam. That's your physician or your provider that's completing your exam. That's having someone actually look and make sure that there's no changes in your skin, making sure that there's no dimpling of the skin. Then they do the breast exam, so they're looking for any unusual masses within the breast tissue. They're also examining your lymph nodes and noting any abnormalities of the nipple.
Okay, so that doctor's going to be probably doing a little bit more experienced look than...
It's a lot more comprehensive, yeah.
Not that you don't recommend the self-exam, though, too.
I do, once a month, that too.
That needs to be done, too.
Yeah.
Is it showering, too? I remember that was one of the things that they recommend, like after a shower, is that?
Yeah, you can either do it while you're showering if you find that it's easier with soapy water. Some people prefer to do it while you're lying down, but I just tell people to be consistent once a month, preferably not when you're having your period, and then you'll get used to what your breasts feel like, and so that if there is an abnormality, you'll be the first person to pick it up.
You'll know something's not, this is not what I felt before.
Yes.
Okay. While we're here, Jackie Engstrand, you've been manning our Facebook page, which has been going very good, and answering some of the questions. So again, you've got another trained pair of hands who's been answering some of your questions on Facebook Live here. We want to talk a little bit about the Knitted Knockers program. It's kind of a cheeky, as you would say, kind of fun thing. But Nurse Jackie, tell us about this program. It's kind of unique, at least here in Kern County, right?
The Knitted Knockers are a soft, comfortable breast prosthetic that are knitted by all local ladies in Bakersfield that patients can wear in their bra rather than wearing the heavy silicone gel ones that they're given by their insurance companies.
And tell me about how this came up. Was it just from hearing from patients saying these things are not comfortable?
One of my patients told me about the Knitted Knockers, and I've been knitting since I was a little girl, so I decided to look into it. And then figured I can't knit them all on my own, so I went on search for knitters in town, and I found a wonderful knitting guild called What the Knit. And it's got about 150 ladies and gentlemen in there, and they have helped me to get this knitted knocker program off the ground. So we've given out about 450 knockers in 2 years.
Wow.
So it's been wonderful, and the patients love them.
Beautiful Bakersfield Award this year, too.
We did, yes, for the humanitarian group.
Which is great. I mean, this is all volunteer, right? Nobody's doing this for money or anything else like that.
No, and they're always free for the patients.
What is it like? I mean, so the patients love them. I mean, it's got to be, obviously, for a woman who's had a mastectomy, who's lost a breast now, this is a life-changing, right, altering. Self-image is a huge thing.
Yeah,
right?
yeah. And then the prosthetics that they get given are very heavy, and they're hot and sweaty. And of course, we have triple-digit temperatures many days of the year, so these are much more soft and comfortable for them to wear. Plus, they can wear them soon after surgery. As soon as their drains are out, they can put the mastectomy, the knitted knockers in
there. And do you guys have people joining the group at any point, or people wanting to help more than you have? And how can people like call, or who do they call if they wanted to?
They can give me a call at the breast center for more information on the knockers, either of where to get the information from. The patterns are available at knittedknockers.org.
Oh, there's patterns. These are patented.
Yeah, no, the knitting pattern.
The knitting pattern, right?
Pattern.
Yeah.
They can be knitted or crocheted, either one. The patterns are available for free download. I also have them in the breast center. I can provide yarn to knitters or crocheters if they need some yarn to knit some. And we also have a knitted knocker stuffing party coming up on October the 7th from 2 till 4 in the afternoon on a Sunday afternoon at the Twisted Skein, which is our local yarn store who are big supporters of the knocker program.
This is just fantastic. I mean, this is just people from the community who thought, hey, this is a need, and if we can make a woman more comfortable going through this process, this is what we can do, right?
Yeah, and you would never know that they weren't real knockers.
And do you guys need donations at all, or do people just donate?
We're always looking for donations. I buy yarn so that the knitters can, because the knitters generally buy the yarn themselves, but I like to provide them yarn if we can. It has to be a certain type of yarn. We can't accept any yarn for them because some of the yarns are too rough and on the patient's skin after they're having surgery in that tender skin. So we have special yarns that we use. So I buy yarns, I buy the little bags to present them in.
And Jackie, we should note too, there is a knit-off, if you will, right, for the VI Pink event we were just talking about a few minutes ago. Yeah. And tell us about that. Too bad we didn't remember there being pictures for this, but I can't remember who won last year, but they vote at the VI Pink event on...
The deadline to hand in the knitted knockers for the knitted knocker knit-off is today.
Okay.
They will be on display from Monday morning through our VI Pink event. There's 3 categories, the most creative, their best interpretation of the theme, and you can choose whatever theme you want to and interpret however you wish, and People's Choice Awards. So we encourage people to stop by the Cancer Centre next week, and there'll be ballot slips out by the display, and they can vote for whichever their favourite knocker is.
I'm trying to remember which one I voted for last year, but I mean I remember them being like a Pokemon or something. There was an Elf on the Shelf theme, I think.
It was a gnome in his home. That was the most creative. And the one that won People's Choice was boobies buzzing by, because they were bees
on there.
Yeah,
it's great. This is a fantastic program, and you know it is helping so many women as they're going through this healing process, because this is a mind, body, and soul type thing. It's a spiritual thing that you're trying to help this woman feel whole again after going through the surgery.
And the knitters love doing it too. Right. It's great. It's a great program.
That's fantastic, Dr. Haney. I got one more question for you. This is from Kathy. At what age do you recommend the mammogram program start for young ladies? What age? Because there was a huge debate about this. I remember, I want to say earlier this year, I can't remember which medical group came out and said 40, maybe not so much, wait until later. What is your thought? What's the national standard on it?
We still recommend 40.
Okay.
So 40 to start with for your baseline, 10 years before the earliest person in your family got breast cancer if you have a family history of breast cancer.
Okay, so it's important still to get that done. And one of the other things that we wanted to say is the care that you get at AI's Cancer Center, I know you like to talk about this, is the same that you will get anywhere else. The standard of care, which is great, right? We're bringing, Adventist Health is bringing a standard of care here that you would get at UCLA, USC, any of those big tertiary care systems that you would think, are doing the gold standard work. That's the same work that we're doing here.
Yeah,
right?
We're a nationally accredited breast center. We have an NAPBC. We're also a breast imaging center of excellence. So we follow, kind of above and beyond the national guidelines at AIS. Like I said, we have a multidisciplinary tumor board. We have medical oncologists, radiation oncologists. We have social workers to help with patients, financial assistance as well. We have social workers. We have a nurse navigator. Jackie's our nurse navigator, and lots of other programs for patients to work on. Such as Tai Chi, Meta Yoga,
painting,
diet, right? Nutrition's a big thing, right?
So it is a real comprehensive. So not only do we treat the patient when you're diagnosed, but we go through all of the facets of your care, and then even afterwards, part of that survivorship and trying to promote, wholeness and health after you're diagnosed and after you finish your treatment.
Right, which is kind of the spiritual part of all that. So again, we appreciate everyone for joining us here today. 637-8720 is the number to the breast center over at Adventist Health, the AIS Cancer Center, 637-8720. So if you're wondering, you have some questions, if I have a family history of breast cancer, or I'm not really sure who to turn to, these are the folks, these are the experts. Again, this is all they do. 637-8720. You can also find more information on our website. That's ahbakersfield.org. And we'll be continuing to answer questions if you want to post them here on this Facebook feed, on this live feed, to kind of figure out if you guys have ongoing questions, because sometimes people are afraid to ask questions, about this serious topic. We'll continue to answer them. And again, this is on the verge of October, which is Breast Cancer Awareness Month. If we can save one life just by raising the awareness of women doing self-breast exams and going out and not being afraid to go see a doctor because something just doesn't feel right? I mean, I can imagine that's not something people are wanting to have to do, but facing that question is probably the first step, right? Of getting an answer at least.
Yeah, and we're here to help.
Right.
That's what we're here to do.
Of course. All right. Dr. Haney, Jackie, thank you guys so much. And thank you guys so much for watching live here on Facebook on this Friday. And again, we'll keep answering questions on this Facebook feed, ahbakersfield.org. And we'll see you next time on the Adventist Health Wellness Connection.